Haematology consultants, and this is a PowerPoint presentation on hematological malignancies. This is quite a detailed presentation. I'm going to try and condense it as best I can into 15 or 20 minutes, but there's lots of information on the slides and in the notes for you to digest in your own time as and when you can. Okay, so just the kind of key principles really is that hematology is divided into predominantly lymphoid and myeloid, depending on the cell of origin, and malignancies fall into those categories as well. And the malignancy really behaves in the same way that its progenitor cell or its benign counterpart behaves. So it lives in the same parts of the body. It tries to do the same sorts of things, but obviously with a malignant kind of bias. So that gives you some idea as to how it's going to behave and what the clinical features are. We usually, for diagnosis of any kind of hematological malignancy, we need history, examination, and investigations. And the investigations are usually some tissue, biopsy, or a liquid sample, but often a solid tissue biopsy. The treatment depends on two things: the grade of the malignancy, so how aggressive it is, and that's usually how fast it's dividing, and the stage, so where it is in the body, how extensive it is, and that usually requires some imaging, either a CT or a PET scan. And then our treatments are becoming more and more refined according to the genetics. For that, we usually do various investigations, which I can talk about at another time, but we'll touch on those as we go. So this just reminds you where all of our hematological cells come from. So they start off in the bone marrow as a stem cell, a hematopoietic stem cell, which can become either a lymphoid progenitor or a sort of lymphoid stem cell, or a myeloid progenitor, myeloid stem cell. And these cells are fairly rapidly proliferating and differentiating down their various lines into the different myeloid compartment cells. So you've got your platelets here, you've got your red blood cells here, you've got your your granulocytes here, and your monocytes. And then you've got your lymphoid cells, which differentiate into your lymphoblasts, and then go down into mature B and T cells and dendritic cells in the tissues. Now, malignancy can occur at any stage here. So if it occurs early, then you've got an acute leukemic type presentation. That's like acute lymphoblastic leukemia or acute myeloid leukemia if it's occurring here. And then further down it occurs, you get different disorders. You can have a chronic myeloproliferative disease, chronic myeloid leukemia, where you get lots of these types of cells. So there's a sort of mutation occurring early on around this area. Or you can have an essential thrombocythemia, which is where you have a mutation occurring at this stage here, making lots of platelets, or a polycythemia vera, where you have a mutation probably occurring around here, which is where you make too many red blood cells. And the lymphoid malignancies, really, if mutations are acquired at this stage, you get an acute lymphoblastic leukemia or acute lymphoblastic lymphoma, which are very similar conditions. And if the mutations occur later, depending on where they occur, you can acquire mutations here, which would lead to a myeloma disorder, a plasma cell dyscrasia, or you can have mutations here, which would give you a low-grade B-cell lymphoma, or if these mutations occur in the germinal center of the lymphoid tissue, then you can have a more high-grade disease, high-grade B-cell disease or T-cell disease. So we're going to start with myelodysplasia, MDS, and acute leukemia. Oops. So myelodysplasia, I've given a definition here. Basically, for myelodysplasia, you have genetic mutations occurring in the bone marrow, which give you cytopenias. You have to have cytopenias. You have to have anemia, low neutrophil count, or low platelet count. It predominantly occurs in older patients. It's an age-dependent thing. And it's classified according to the World Health Organization. You don't need to know the classification. And it occurs due to mutations in the myeloid cells in the bone marrow. It normally presents with cytopenias, anemia, low platelets, low neutrophil counts, which can lead to infections or bleeding or fatigue. But it's a more slowly progressive disorder. Um, the prognosis depends on the number of mutations that are present. Sometimes it can be very rapidly progressing into acute myeloid leukemia. That can take over six months or so. Sometimes it can be much more indolent than that, with just a single mutation or a few relatively benign mutations which lead to a more indolent form of myelodysplasia. And the management for myelodysplasia really is support. So red cells, usually only if the patient's symptomatic, not on a particular hemoglobin level. Platelets we tend not to support, even if they're really low, unless there's bleeding or unless the patient needs some procedures doing. And then infection control, and prophylaxis, so antibiotics, antifungals sometimes, and careful vigilance and education for the patient. Occasionally we use chemotherapy, so drugs, gentle chemotherapy, because often the patient's quite elderly who presents with myelodysplasia. There are various drugs we can use. Sometimes if the patient is young and develops myelodysplasia, then we can use more intensive chemo in the knowledge that the likelihood is that it would probably go on to form acute leukemia eventually. And we can even go ahead and do a transplant, but that's relatively rare. Myelodysplasia is generally a disease of the elderly. It's generally treated with supportive care, occasionally with gentle chemotherapy. Okay, acute myeloid leukemia, which is sort of a much more aggressive disorder than myelodysplasia, but has similar origins in that there are mutations in the cells in the bone marrow, the myeloid progenitor cells. To make that diagnosis of acute myeloid leukemia, you need greater than 20% blasts, but they can be either in the peripheral blood or in the bone marrow. It doesn't have to be in the peripheral blood. Sometimes you see very little in the peripheral blood, just cytopenias. It normally presents with cytopenias, so bone marrow failure, because of too many of these blast cells here. This is a blast cell in the bone marrow. And sometimes the blasts spill out into the peripheral blood. These 1, 2, 3, 4 cells here are blasts in peripheral blood. Patient usually can present with bleeding or bruising because of low platelets, infections, pneumonia, or just neutropenic fever of unknown origin, and anemia, so signs and symptoms of anemia. As I say, you need 20% blasts in either the marrow or the blood to make the diagnosis. And then once the diagnosis of acute leukemia has been made, we then do special tests on the cells where we look at their surface markers, something called immunophenotyping, to see which molecules they're expressing. And that tells us that this is myeloid, not lymphoid. We can also do molecular genetics, where we amplify nucleic acids in the lab to look for particular gene mutations such as FLT3 there, or NPM1, or something called PML-RARA, which is present in acute promyelocytic leukemia, which is an important sub classification because that has a propensity to bleeding, and it's treated slightly differently. How do we treat it? It depends a bit on how well the patient is, how fit they are for treatment. It's often the disease of the elderly. Patients may not be fit for intensive chemotherapy. It depends on their comorbidities and their frailty. But if they're fit and previously well, we would usually use induction chemotherapy, high dose chemotherapy, bring them into hospital, get them into remission with a month's worth of treatment, and then reassess the marrow, maybe go on and give 2 or 3 more cycles. And if they were young and were very fit and had a certain prognosis from their myeloid markers, then we would think about an allogeneic transplant, a transplant from someone else. Okay, acute lymphoblastic leukemia, again, the diagnosis depends on 20% blasts. It presents often in younger people, children. The ratio is about 5 to 1 for children to adults, compared with myeloid leukemia, which is the other way around. It's more likely to be in older adults than children. The genetics and the karyotype are really important in terms of prognosis. In children, you often see what's called a hyperdiploid, so too many copies of various chromosomes, and that can be a good prognostic marker. It's sometimes accompanied by the Philadelphia chromosome, which we'll come on to later. Acute lymphoblastic leukemia is a predominance of the leukemic form, so lots of blood, lots of blasts in the peripheral blood. Acute lymphoblastic lymphoma is a very similar disease, but you tend to have larger lymphoid masses, lymphadenopathy, but it behaves in a very similar way, aggressively, T cell or B cell, and often if it's ALL, it can be T cell lymphoma if it's in the chest. Again, it presents with bone marrow failure, infections, low blood counts, anemia, bleeding. The diagnosis is made by the bone marrow biopsy and with peripheral blood, immunophenotyping and cytogenetics. And the treatment is usually, if their patient's fit enough, with induction therapy, chemotherapy, to get them into remission with or without a bone marrow biopsy. There's some good notes there that I've made to give you a bit more info. Okay, myeloproliferative disorders are a myeloid malignancy. They are a kind of malignancy. Chronic myeloid leukemia is the one that most people have heard of. This was identified by a couple of scientists working in Philadelphia who identified the Philadelphia chromosome, which is associated strongly as the genetic mutation. And Janet Rowley was another scientist who helped characterize that. It's often characterized clinically by splenomegaly and high blood counts, but it usually occurs slowly over time. So you have a chronic phase of several years, which is why it's not the same as acute myeloid leukemia, which comes on usually over weeks to months. The blood cells that you see in the peripheral blood are mature, so they're not blasts, they are granulocytes usually, and sometimes high platelets as well. And it responds really well to targeted molecular therapies. This just gives you a bit more detail on chronic myeloid leukemia and tells you about this drug called imatinib, which blocks the protein, which is the product of the Philadelphia chromosome here, and stops the protein from causing the cells to proliferate and make lots and lots of granulocytes, which is what you can see here, which is a classical blood film of chronic myeloid leukemia. And this just shows you that the prognosis used to be really poor. Back about 10, 20, even 30 years ago, really, it was very poor because we didn't really have very good drugs, and most patients went on to form acute leukemia. Now the prognosis is very good, and that's because we have targeted therapies which are not chemotherapy drugs, but that they can target the protein made by the gene and makes the life expectancy excellent for patients with this disorder. There are other myeloproliferative disorders, essential thrombocythemia, too many platelets in the peripheral blood, usually caused by a mutation in something called JAK2, or there are other mutations. It's treated, it presents sometimes with bleeding or clots because of high blood platelet levels, which are persistent, and it's treated with cytoreductive therapy, so reducing the platelet count, usually with a drug called hydroxycarbamide. Myelofibrosis, which presents with these like teardrop red blood cells and anemia, and also with B symptoms, sweats. It's quite an inflammatory disorder and often splenomegaly. Again, JAK2 mutations are present in some cases. The mainstay for care for myelofibrosis is usually supportive, so red cell transfusions, supportive care. Sometimes we use drugs to help with the symptoms of splenomegaly. And then polycythemia vera, which is where you have too many red blood cells. And that's again related very strongly to the JAK2 mutation. And treatment is either with drugs, hydroxycarbamide, to bring down the red cell numbers, or by venesecting, so bleeding the patient every few weeks or months to take off some of the red blood cells and keep their numbers around normal. Okay, so lymphoma. How are we doing? Bit behind time, but we'll catch up. Lymphoma is divided into Hodgkin's and non-Hodgkin's, and we're going to talk about non-Hodgkin lymphoma first. So I'm not going to go into too much detail over the pathobiology. I'll leave you to review that in your own time. The majority of lymphomas are non-Hodgkin's. About 2/3 of them are non-Hodgkin's, and then we have what we also classify in this bracket really are CLL, chronic lymphocytic leukemia. Although it's a leukemia, the cells are lymphoid, and they live in the lymph glands as well. So you often get lymphadenopathy as well as a circulating peripheral lymphocytosis. Myeloma, which confusingly is not a myeloid disorder, it's a lymphoid disorder. These cells are plasma cells. They make antibody. They live in the bone marrow, which is why it's called myeloma, because that's the myeloid is of the bone marrow. And aggressive acute lymphoblastic lymphomas, which we've really talked about in the same bracket as ALL. And then Hodgkin's, which is a small proportion of the lymphomas that we see. Lymphoma, non-Hodgkin's lymphoma, is really associated with age, so it increases in its incidence with age. Non-Hodgkin's lymphoma, that is. Hodgkin's is a bit more sporadic. It can really occur at any age, but there seems to be some subtle peaks in the 3rd and 4th decade, and perhaps again towards the end in the 8th or 9th decade. If we're talking about non-Hodgkin's lymphoma, about half of it is aggressive and half of it is low grade. And the aggressive form, most of the aggressive forms, the high grades, are what we call diffuse large B-cell lymphoma, B-cell lymphomas. A little bit is Burkitt's lymphoma, which is very aggressive. And then the slow growing or the low grade lymphomas are a real mixture. Some of it is marginal zone, which just refers to the bit of the lymphoid follicle that's involved. Some of it is follicular, that's the lymphoid follicles are intact in the bone marrow. That's a histological description. And we see a little bit of T-cell lymphoma, but T-cell lymphoma is a very unusual and relatively rare and aggressive, relatively aggressive but slow growing. I say aggressive but slow growing. It's slow growing, but it doesn't really respond to treatment very well. So lymphoma, how does it present? It can present with weight loss, with B symptoms, so that's drenching sweats, weight loss of more than 10% over 6 months, and lymph gland enlargement, and fevers. So the B symptoms are fevers, weight loss, and drenching sweats. Weight loss is the most reliable because it's objective, you can measure it very well. And then the lymph glands can occur anywhere actually. So you have lymphoid tissue in your bone marrow, in your peripheral, in your intestine, around your lungs, in the middle of your chest, in your neck, under your arms, and in your groins. And really, we think of painless lymph gland enlargement. It's usually painless, and it tends to persist for more than 3 or 4 weeks, and slowly grow if it's a low-grade lymphoma. So it'll slowly grow over months to years. Sometimes it stays the same for many years and doesn't need any treatment. And more rapidly grow if it's a high-grade lymphoma. So it grows usually over weeks to months if it's a high grade. To get the diagnosis for lymphoma, you need a biopsy, usually a tissue sample, a core biopsy from a lymph gland, and that's almost always the case, either the lymph gland itself or a core biopsy, not a fine needle aspirate. Once you've got the diagnosis, then you do the staging. So then you do a CT or a PET scan. We do CT scans for low-grade lymphomas and PET scans more so for high-grade lymphomas. PET scans are a bit more sensitive at picking up where high-grade lymphomas are, and they might just show you areas that you didn't see on the CT scan. That's why we use them more. Hodgkin lymphoma, we would normally always try and do a PET scan at the beginning and then after a couple of cycles of treatment. Non-Hodgkin's high-grade lymphoma, we try and do a PET scan at the beginning to see where the disease is, and at the end of the treatment, maybe sometimes with a CT in the middle, a normal CT, just to see if it's responding well. But for low-grade lymphomas, we tend to do a CT scan, a CT thorax, abdomen, and pelvis alone, without a PET scan, although that might change in the future. We would need to check their bloods, kidney function, liver function, and LDH, because that can have implications for the score of the lymphoma, the prognostic score. We always check for viruses, hepatitis C, B, and HIV, partly because sometimes HIV can be implicated in lymphoma, and partly because the immunotherapy that we use can sometimes reactivate those if the patient's carrying them without knowing. And then because we're giving treatment for any of these disorders, either lymphoid or myeloid malignancies, we like to know if the patient's got other problems with their kidney function, liver function, and considering a cardiac echo, particularly if the patient's over 65 and has a history of heart disease. So staging for lymphoma is based on the Ann Arbor classification, and the classification is described here. The principles of treatment for lymphoma are high-grade disease normally requires treatment straight away, and low-grade disease only if it's causing symptoms. High-grade disease is normally treated with immunochemotherapy, as is low-grade disease actually, but we have various new agents as well nowadays. I've done a little bit on the adverse effects of treatment. We need to think about fertility, particularly when the patient is of childbearing age. A lot of our lymphoma treatments don't affect fertility, but the more intensive ones can. And so patients can be counselled about that before starting and can opt for sperm banking or egg banking beforehand. We need to think about infections. There's a risk of infections with any kind of chemotherapy. So if we're doing it as an inpatient or an outpatient, we might have them on prophylactic antibiotics and antifungals. We need to think about hair loss, which is very important psychologically to people, fatigue, GI disturbances, constipation and diarrhea are common, nausea obviously, although we have good treatments for nausea, and other individual effects of drugs such as steroid-induced diabetes, and psychological effects. Being given a diagnosis of a malignancy and then having to go through treatment has a big psychological and sometimes economic impact on a family, and so we support them through that with information and help from our nurse specialists and from the medical side as well. And then the late effects of treatment depends on obviously you're using chemotherapy agents which can interfere with genetics of the bone marrow, and we can have late onset myelodysplasia or acute leukemia, sometimes infertility, and sometimes lung or heart toxicity or kidney toxicity because of the drugs. So we have to be careful how we use the drugs according to those things. I've done a couple of slides on some of the commoner types of lymphomas, high grade and low grade, giving you detail which you don't need necessarily, but it might be interested in reading a little bit about. And a bit on Hodgkin's. Thomas Hodgkin was a very famous pathologist in London who described cases in the early 19th century. And then Hodgkin's lymphoma, which we know occurs at any age, but sometimes in the younger patients, characterized by this cell here called the Reed-Sternberg cell, which is probably a B lymphocyte, but has lost its markers for B cell markers, and causes a very inflammatory lymphoid disorder, which often is characterized by the B symptoms. The Reed-Sternberg cell was characterized in part by this pathologist as well. Hodgkin's often presents with a mediastinal or neck mass and is often above the diaphragm at the presentation, although can be both sides. So it can present with cough or shortness of breath or fevers or pain. And diagnosis depends on the histology, so we need a biopsy to make the diagnosis. And then staging depends on a PET scan, so we do a PET scan to stage Hodgkin lymphoma, and then we do a PET scan after 2 cycles to see if it's got better, and that can tailor our treatment. Okay, chronic lymphocytic leukemia is another form of leukemia, but this is a very slow, indolent form. Often occurs late in life, often requires no treatment whatsoever, only if it's causing problems like low red cells, low white cells, or low platelets does it really require treatment, or if it's causing troublesome constitutional symptoms or lymphadenopathy. We have some really excellent new treatments which are not chemotherapy, which interrupt the signaling mechanisms, which have revolutionized the treatment for CLL and made it prognosis very much better than it used to be as well. I'm not going to go too much into myeloma, but myeloma is a plasma cell disorder, so it's a B cell disorder. These are myeloma cells in the bone marrow here. They make lots of immunoglobulin or parts of immunoglobulin called paraprotein, which is like an antibody which doesn't work and is found in these large vesicles in the cells. Because these cells are related to plasma cells, they like to live in the bone marrow, so they go back to the bone marrow where they cause destruction of the bones, lytic lesions here, and that's one of the key features. The destructions of the bones can cause pathological fractures and high calcium, and the plasma, and because it's invading the bone marrow, it can cause anemia. The protein that it makes, either an intact paraprotein or a light chain, clogs up the kidneys and causes renal impairment. So myeloma is characterized by high calcium, renal impairment, anemia, and bone disorders. Okay, that's where I'm going to leave it. I'm sorry I've gone on a bit further than I intended to. I look forward to seeing you in the tutorial. I've set some questions for the tutorial which we can discuss. I've also added some additional notes to the end of this presentation for your own interest if you wish, and I'm more than happy to talk through them if you wish to. Many thanks.